All right, welcome everyone. I think we should probably get started. First, let me apologize. I am at the airport. I was supposed to go fly out last night, but unfortunately, my flight is delayed for 14 hours. So, if you hear announcements in the background, that's please ignore them, and we will try to do our best here. I don't leave until 10:50, so plenty of time. I'm not in a rush. Anyway, thanks for joining us. Andy, can we have the next slide, please? This is just general information about cardio, which you should be familiar with. Next slide, please. And today I will be doing, I guess, quite a bit. So we'll have until about 8:33, including the case discussion as well. Next slide. And these are our sites. Next slide, please. And this is our team with which you should be quite familiar as well. Next slide, please. And no disclosures of significance. Next slide. And to get CME credit, I hope you guys are applying for it. It's certainly something that is easily available to you through CASE. Next slide. And MOC, I just finished my MOC. This project does qualify if you are ABFM certified. So this is the site to go to for that. Next slide, please. And remember, do not disclose PHI while we are talking about our projects. Generally, that's not much of an issue in this particular series of echoes since we don't talk about individual patients. But even inadvertently, please keep that in mind. Next slide. So today we are talking about the joy of work, which this morning I'm not experiencing right now. But nevertheless, I want to tell you to some extent how I got to this field and why it's important and how it's related to QI as well. I think is the most important thing. Next slide. So the objectives today are threefold: to define burnout, and I'm sure everybody has heard that term, and then to describe three strategies to prevent burnout and promote joy of work. So there's quite a bit of research in this area over the last 10 to 15 years, and we are going to try to distill it down to a few basic principles and describe a plan to measure burnout among clinicians, which we'll talk about during the case study as well. Next slide. So everybody has heard about the issue of burnout. It came to the forefront, I believe, during the pandemic. You probably remember news reports of, from New York City in particular, healthcare workers going into emergency rooms trying to handle patients with COVID, really being hailed as heroes. Many of us lost some of them due to COVID as well at that time. But it was a point at which I think many physicians, nurses, and others just felt they couldn't go on, that this was way too much. But even prior to that, so more than 8 years ago, almost 9 years ago, this influential blog appeared in Health Affairs, and it's signed by many CEOs. You'll notice Toby Cosgrove from Cleveland Clinic listed among them, who said this is a public health crisis, and nobody was really tackling it. So at the time, I had been a chair for less than a year, and I can tell you that every health system was appointing someone to manage burnout and wellness and that sort of thing, and they go by many different names. Generally, wellness officer was the title. When I started as chair, the chairs were divided into separate committees. One was the patient access committee, one was the finance committee. I did not want to be on the finance committee, but I wanted to be on the patient access committee, but it was full. I was told by our current CEO, so I was asked to join the wellness committee, and since I was the only one on the wellness committee, I was also the chair of the wellness committee. And after a while, that title and that role grew into an actual formal position. Next slide. So let's talk about burnout in a little bit. So there's different levels of experience with one's job that lead to burnout. So first of all, I don't like this, and everybody feels that way all the time. I can tell you, my two clinical days, I sometimes I experience that. Everybody does. Then there's disengagement. I don't want to do this. I want to do something different, or I really can't stand doing it. And of course, burnout is when I just can't do it. I have. They actually literally will stop and say, "This is no, I cannot do this any longer." I've met with clinicians who are in that position across specialties over the last 8 or 9 years or so. Next slide. So there are three principal components, and these have been validated, these have been documented across specialties, settings, countries as well. So there's a high level of emotional exhaustion, which one can relate to, I'm sure. Um, and that is the first step. The next one is a low level of personal accomplishment or efficacy. When you start off in clinical practice after finishing residency in medicine, for example, you often start with a lot of optimism. You can see the path ahead of you, and others who are far much further along in their career say, "Look, I've accomplished a great deal," and or perhaps they're just very content with what they've done. It's people in between that experience the sense of low personal accomplishment and efficacy that can lead to burnout as well. They're not sure what comes next. They're 45, 50 years old. They say, well, I have to keep doing this for a while, but I don't feel a sense of accomplishment. And the worst symptom, of course, is depersonalization, where you depersonalize patients and your colleagues, and cynicism as well. Next slide. So burnout has serious consequences. We don't want to spend too much time. From our standpoint, it is associated with decreased quality of care, an increase in medical errors, decreased patient satisfaction. These, of course, are firmly related to QI, decreased productivity and professional effort, physician turnover. On a personal level, broken relationships, substance abuse, depression, and unfortunately, physician suicide or clinician suicide as well. Next slide. Um, so that's been well documented. So what do we do about this? When you survey people that include healthcare executives, clinical leaders, and clinicians, there's a remarkable degree of consistency as to how to address the problem. One is to reduce regulations for medical documentation and clerical work. Uh, as a primary care doctor, I can tell you that would be my priority as well. And then streamlining the EHR, making the EHR easier to use. And here's the other thing: a lot of people um, are concerned about instilling wellness programs, etc. So this is probably not the best way to go. So resilience and wellness programs have minimal impact, I think, on how people perceive the addressing the issue. Other educational programs for leaders, etc., are even lower ranked. Next slide. So let's talk about clinician experience. So we chose at university hospitals not to use the term wellness. Our clinicians were kind of resentful of the term because it implied that they were unwell or that they needed therapy. Nobody liked it. So we adopted clinician experience, and clinician experience can be defined as how an individual clinician perceives the quality of his or her work life as reflected by activity in clinical care, teaching, and scholarship. Um, this is a challenging definition because, first of all, it's how you perceive it. Okay. I love seeing patients on Monday. I see a lot of them, about 25 in about 7 or 8 hours. And I enjoy it. I enjoy going from room to room, joking around with them, doing a little history there, getting a woman ready for a gynecological exam, then zipping in there. That's how I do it because I don't have many opportunities to see patients. And so, but I can tell you, our residents would dislike that very much. They want to move sequentially. They want to spread out their clinical work over a period of time. But so it's not really how I feel; it's how the individual feels under circumstances. You cannot judge based on clinical load or setting or specialty, whatever. Everybody has a different experience. Next slide. Um, Clinician experience wellness, the connotations, as I mentioned, imply being unwell. I've never heard of any place that has a chief burnout prevention officer. Burnout is the ultimate expression of poor clinician experience. If you have some sort of, if burnout is, preventing burnout is is in the title of your role or is part of the job, something is seriously wrong. Next slide. So, fortunately, burnout has decreased. It peaked, of course, as you can imagine, in the COVID-19 pandemic, but it's still a significant problem. The leaders in this field are Colin West, who is actually a collaborator of mine in a completely different domain. This deals with meta-analysis and prevention studies, but he also happens to have expertise in burnout. He's a general internist. And Tate Shanafelt at Stanford, who is their wellness officer there, who is probably the leader in the country. Next slide. So, how do we prevent burnout? I started to talk about documentation as an issue, regulations, the electronic health record. And even though, for example, Epic, which we use and many of you use, has improved dramatically in the last few years, there is some potential for artificial intelligence to reduce physician burnout and to engage patients and clinicians in more meaningful clinical encounters. This is a very recent study from Yale that has shown this, actually just a few weeks old. Next slide. But let's talk about overall trends. So there's a lot of excitement about AI. So Mayo Clinic, in whose pathway I have just copied, to be honest, Colin just said, here, you've got this new title, here's what you need to do. We've been doing this for 20 years. And he's an expert. He's published and done all kinds of things. First of all, you have to acknowledge the problem. To say that your clinicians are not burnt out or there isn't one is to fail immediately. Harness the power of leadership means appointing someone who's responsible for this. Develop and implement targeted interventions means looking generally at where the problems are, where the pain points are, and targeting them. Not to say, well, we've got aromatherapy at 5 p.m. up in the lounge. That's not going to do anything unless you really look at the problems. Community at work. We've had this for a long time. I think we call it Community Wednesdays. At Mayo, it's called Community Tuesdays. So we just copied it. It's just bringing clinicians together with food and a little bit of food and sometimes alcoholic beverages as well. Everybody's welcome. Using rewards and incentives wisely is something we do really poorly at, for example. So, a little bit of extra money to be more productive is often can backfire terribly. It sends out the message that the health system only cares about the bottom line. Aligning values and strengthening culture, making sure we are all aligned. The flexibility and work-life integration is something I tried to work on. It is very, very, very challenging. But there are a lot of talented people, not exclusively women, but predominantly women, a lot of talented women who would appreciate more leadership roles, more flexibility. And my goal as a chair is to say, tell me what you would like to do and let me see if I can make that happen on an individual level. On a system level, it's much more difficult because every unit, every department, every specialty is different. If you offer flexibility and work-life integration at a higher level in one unit, it becomes an equity issue that has to be addressed. So it's difficult, no doubt about it. Now, way down at the bottom is provide resources to promote resilience and self-care. We have lots of those. We have a counseling program, a peer support program, et cetera, et cetera. Everybody has those. I'm just looking around the room. Metro has it, Ohio State has it, everybody has those things. And finally, facilitate and fund organizational science in this area. Extremely difficult to do. The NIH does not fund studies of burnout prevention or anything of that sort. So you are really limited in terms of where you can gain those resources. Mayo, Stanford, and other places have done much better than we can here. Next slide. So what should you do as small practices? First of all, there's no doubt that your clinicians may be experiencing the symptoms of burnout as well. And you've probably witnessed that. You may be experiencing them yourself. So you don't need to, as a large system would do, to harness and recognize the problem. You can recognize it right away. You can't fund organizational science. You may not be able to structure community building programs. But you can measure um, symptoms of burnout. And the best way to do that is this very, very simple mini Z survey that has been validated, has been used for greater than 10 years. I strongly encourage you to download it. And I strongly encourage your clinicians to complete it, not just physicians, but anybody that has any contact with a patient, including your front desk staff, should be completing this as well. And it gives you some inclination as to whether your environment is supportive or not. It literally takes about 2 minutes to complete this, and it's very easy to score as well. So please do that. Next slide. So, as chief clinician, experience officer, my personal interests can overlap with this role. So there's no prescriptive um, definition of what the role will entail. And Dr. McGarrian has said, just make something happen. Part of it, I don't mean to sound cynical, but many systems were appointing someone just to have somebody in place, so that clinicians could turn to them and say, "Look, we've got some programs in place. We're no different than Ohio State or University of Rochester or Metro Health. Everybody has somebody." But because I have a broad mandate, and it's not limited to running EAP programs or counseling programs or confidential hotlines, I chose the creative arts in particular. There is very strong evidence that engaging clinicians in creative arts interventions reduces burnout and psychological distress. There's a number of studies. This is just one in particular that I happen to like. Next slide. So my personal interest is in writing. As many of you know, I have taught writing skills for 26 years. And to physicians, I am affiliated with the Department of English at Case Western, and I have been with many other institutions, including the University of Oxford. It is literally a second life that I love to share with my clinician colleagues. I do not share my clinician life too much with my humanities colleagues. There's a lot of resentment there. It's like, well, you already make a good living. Why are you here with us? You're not a starving artist kind of thing. So you have to be careful about how you do it to go the other way. But this way is a lot more fun. So there's no question that writing and helping people to write has some impact on empathy. This is the famous Yale Physician Writers Workshop, which is only open to residents, by the way. But I thought this research was convincing. All it says is people like it. But of course, people who like it are the ones to enroll in it. There is some evidence that when you write about traumatic events in your clinical life, it can help you process them more effectively. A traumatic event does not necessarily have to be a patient death or a lawsuit. It can just be a very difficult day, and keeping a diary helps a great deal. Next slide. So we do have a program, as many of you are familiar with. Some of you may be part of it, called Words for Wellness. Its mission is to learn, to share, to grow, and to find peace through writing. We started it in early 2023. It is an outcrop of Stanford's program. Some of you might have heard of the Stanford Pegasus Physician Writers Program. I'm still an instructor for the program. It was started by the very famous novelist Abraham Verghese, who's no longer involved, as well as Hans Steiner, who passed away. And then they had a leader, and they are in a state of chaos right now. The problem with the Stanford program is that if you're joining by Zoom and trying to teach Stanford physicians who get off at 6 p.m., that's 9 p.m. for us here in Cleveland. By the time they settle in, it's 10 p.m. That's my bedtime, so I couldn't do it anymore. So they said, why don't you start a Stanford Pegasus East program? And that's what we were called initially, but I haven't found any real benefit to having that particular label. So we have started our own program, and it's called Words for Wellness. And it brings together clinicians. The only requirement is that you have something to do with Case Western. An appointment of some sort. You can be affiliated with one of our hospitals. It doesn't matter whether you're a physician or a basic scientist. We have people from across the spectrum, and they are learning to write creatively and trying, hopefully, finding some peace. Next slide. So the motivations for people in this particular program are writing for well-being in a very narrow context. So if I say to you, you've had a really rough day, let's sit down and write about it. Not going to go over very well because you probably want to just relax. You don't want to think too much. So emotional processing, but most of our members want to write to add a different dimension to their professional and personal lives, and that's really, really important for them. Next slide. So here's the context. If I said at the end of a day, and this is how a lot of these programs take place. So there's a music therapy program at noon. I know some of you might be at UH or elsewhere. There's one at Cleveland Clinic as well. Um, the idea is to gather at noon and to have some music therapy. Well, I'm usually either have a meeting or I'm busy seeing patients or I'm busy doing something else. I'm not going to go upstairs to sit in on music therapy. So that isn't the right way of doing it. So at the end of the day, if you bring together a bunch of clinicians and say, let's do some poetry reading and it'll help you deal with your burnout, it is not going to be successful. That's not the right way to do things at all. Next slide. The right way to do things fundamentally is to help people achieve something through their writing or their poetry or their music or whatever it happens to be. So I am able to pursue my three passions, of course, which is seeing patients and doing research and trying to prevent heart disease, literature, and music. But we'll save that for another discussion at some point. Let me stop there and see if there are any questions.
Gautam, this is Vas.
Go ahead.
Sorry,
Uh,
Gautam, this is Vaskar. You did touch on AI, how it is now and in future going to assist with our work. For instance, preparing a discharge summary who has been in a hospital for an extended period, AI can quickly
yeah.
give you a short discharge summary. The problem is that then the employers or the clinics are then going to want the physician to take on more patients and more work to do. So, any comments on that?
Yeah, I touched on it, Vasco, because this is a rapidly moving area. So there's three big domains for AI. One is analytics, analyzing databases to come up with insights. Hey, your patient's going to be late or they're going to be a no-show. The second one is facilitating documentation and reducing workload, which you hinted at. And the third one is AI interacting with patients for counseling and stuff. That's my particular interest. But I think that I have been to a couple of AI meetings where health and with health system CEOs, and they all agreed that we are not going to use AI simply to expand workload and try to make people more productive. That's what, at least that's where they endorse that view. So the discharge summary example is a good one. Those discharge summaries are pretty good, by the way. I was amazed at viewing them. Or for example, since you can document your outpatient encounters more quickly with ambient AI, we're going to add an extra patient to your workload. So what you're doing then is you're changing the metrics, the RVU metrics by which people have to complete things. That is not the idea at all. And if you do that, you're not going to prevent burnout as well. So at least what they say, they're saying the right things right now. We'll have to wait and see if the metrics change. In my health system, nobody is adding patients when they're using ambient AI. Nobody's adding patients to the schedule. They're retaining the schedule. People are able to finish a little earlier, get their lunch, get home by 5:36 or whatever it happens to be. But great question.
Very nice presentation, Gautam. That was very helpful. Thank you very much.
Thank you. Any additional questions, comments?
So
Elise, go ahead.
I have and I'm hoping you can help explain this. People like throw around the terms burnout and moral injury like they're interchangeable. I'm wondering if you can explain the difference.
Yeah, moral injury is a situation where something has affected you in a way that is not aligned with your values. Right? If you see something in the hospital that's done, I've everybody has suffered moral injury on one occasion or the other. I can tell you quite often it's doing a procedure, for example. This is what I've witnessed that is completely unnecessary Um, uh, it affects your sense of consciousness and moral injury. Burnout is quite different. It is a transition from emotional exhaustion to a situation where you can't do anything. There's not necessarily a moral injury that takes place there either. And sometimes moral injury can be, I've witnessed something the system is doing, shutting down a clinic, abandoning a group of patients that really affects how I view the system and how I view my role within it. Any additional questions? I am really sorry about all the ambient noise. This is the quietest spot I could find, but okay, I think, Andy, we can move on to the next components. So the clinical pearl will be only a couple of minutes. Some of you have probably heard of cardiovascular kidney metabolic syndrome. It's been a term that's been around for a few years. There is an AHA committee. I'm on the guideline committee. Our recommendations are final. My role is to promote them. There's a lot of work that went into this, and you'll see a very, very large guideline coming out in circulation within the next few months. That's not what I'm here to talk about. The idea is that kidney disease, cardiovascular disease, metabolic syndrome are all general manifestations of the same thing. And I really like the staging is what I wanted to talk to you about. So stage 0 means you are, I'm not going to go into life's essential 8, which is exercise, blood pressure, etc. But you have no risk factors for cardiovascular disease or kidney disease. Stage 1 is people who have excess adipose tissue, obesity. Now, there's clinical obesity, a new definition, which we won't talk about. Maybe we can talk about that as a clinical pearl later. And then there are metabolic risk factors in stage 2, which we're all familiar with, which you all are addressing through your projects. These are hypertension, type 2 diabetes, etc. Stage 3 is a further progression to subclinical cardiovascular disease. These are people who have elevated coronary calcium scores or subclinical heart failure. And stage 4 is clinical cardiovascular disease in the context of kidney disease and other conditions as well that can lead to stroke, heart failure, peripheral vascular disease all along the ways. Now, risk equivalents of subclinical cardiovascular disease are CKD, according to the KDIGO guidelines. I bring this up, and I don't want to spend a whole lot of time on it, is that depending upon what stage people are in, there are different interventions that will be recommended. But I think the more important thing is for you to understand this particular framework. If you have someone who's in stage 0, you can congratulate them. You can communicate that to them and say, you are at stage 0 for cardiovascular kidney, CKM syndrome. And they'll ask, what does that mean? Well, we can focus on preserving your cardiovascular health. Stage 1 means, okay, you've got one important risk factor and therefore and progressing thereafter. So please keep this framework in mind. It's like, I think we talked about in the clinical pearls a while ago that the pooled cohort equations, the ASCVD calculator is being replaced by the PREVENT calculator. We want to start to encourage everyone to start using it as well to predict both heart failure and cardiovascular disease. Any questions about the pearl? Okay, if not, we can move on. And this is just a rationale for staging that I don't want to spend too much time on, but there's a very powerful rationale for it. Next slide. Let's talk about our case discussion briefly, and then we'll turn things over to Amanda in a moment. So Mount Gilead, Ohio Primary Care Associates has suffered from both high rates of turnover of both providers and staff. So this is directly related to the presentation I gave you. Let's say it's a relatively small practice. There are 8 providers, maybe another 8 to 10 staff members, including medical assistants, a couple of nurses, and front desk staff. Lots of turnover. And we know that people are unhappy. So what would be people's thoughts on how you start the process?
Sir, good morning. This is David Blessing from Fisher Titus. I will tell you that this is, for me, been one of the goals when I started. I had multiple turnovers in my offices of physicians and staff, and um, really the first step for me was working on very openly creating an environment of almost reassurance. So I take some of the things off my providers' backs, like filling out time off paperwork, things that really should fall onto a manager. So I alleviate any of those issues where I just get notified, for example, by email of what the providers are needing or asking, or reimbursements of CME or travel, things of that nature. And then I process it for them and then grab signatures, and then that part of their job is kind of um, taken away, so they don't have to worry about that. And in the same token, same thing with staff, is really trying to create an environment that is focused on patients and the staff first, and then the organization. And it's been pretty successful. We really have two good environments where people want to come to work and want to be here. And it's because of the environment and the people around them. So it really, the patients aren't having the same effect as they are in some of the other offices, because the patients can have a very ill effect on my providers. And some days it shows based on how they react, but in most days they're able to handle that. Same thing with the staff; they're able to handle it and um, have better days. So I think starting with that environment really is the place to make it better.
Well, that's terrific, David. It sounds like you've done a lot of interventions already, and I think
Yes.
they're very fortunate to have someone like you. I can tell you, in many cases, and you've done all of this already, it's acknowledging the problem. And I would sit down with the staff and the clinicians and say, hey, let's have a bit of a meeting here. I know not everyone's going to be here, but I'm sensing we've got a problem with turnover. So, in other words, just put it out there. We've got a problem with turnover. People are stressed, people are unhappy. Let's put that on the table. What can we do to make things better? And let me see what I can do, which you're doing very much, a lot of those types of things. So I think that's the key in a small practice. You don't have to have wine and cheese once a month. That's not going to do anything. People won't show up. But at least acknowledging the problem and saying, okay, as you said, if you could process some of our vacation requests a little bit faster, that would be helpful, so we can plan a little bit better. Or if you can avoid the front desk staff from adding new patients on the schedule after 3 p.m. because they take a long time, and that makes the day significantly longer. Those are the kinds of things that you would do. And how would you measure the impact of your strategies? What would you do?
So I think the first part is turnover. So in my first year, it was difficult. I had about an 80% turnover of all the staff that I inherited. And since then, that's dropped down to about 20%. So I lose maybe one, maybe two
Hmm.
people a year. Um,
Right.
but I've only lost one person in the past 2 years to the environment. And it was actually the schedule. She just couldn't work the provider's schedule. So it wasn't necessarily the environment. It really was the schedule just didn't work for her. And I did actually was able to give her to another practice that had a schedule that worked. And
Hmm.
that individual is still here. So it worked very well. We didn't necessarily keep her in this office, but she went to another office, and she fills in here quite often, and she's happy and is still with the organization. So, we're
Fantastic.
really trying to do that.
Okay, before I turn things over to Amanda, I just want to make one final comment. You cannot successfully implement a QI project in your practice if you have an unhappy, burnt out, stressed staff. I mean, David's done some wonderful things. I mean, prior to this whole project, it will not work. They will not, first of all, they will not be enthusiastic about it. And you will be constantly battling, well, why didn't you hand out these questionnaires? Why didn't you do this? Why didn't you call this patient back with high blood pressure? It's because they're not happy in their position. They're going to do the bare minimum. And some people may even be passively aggressive um, uh, towards the project in general. So keep that in mind. That is how QI and joy of work are related. So with that, I'm going to finally get on mute, which I think you'll all be very happy about, and turn things over to Amanda.
Thanks, Goutham. Great, great talk, and so important. Good morning, everyone. Excited to hear from all of you and talk about your QI projects and some of the QI tools that you've been using during this project, so that maybe others can learn from your tools and what you've been using. I don't know that Amber is on from Village of Healing. Amber, are you with us? All right. So I think we'll move on to East Liverpool next. And I think Hen was going to talk to us about their SFMEA, so the short form failure modes and effects analysis. Just kind of overview real quick on what this is. It's really a tool that's a systematic proactive analysis of a process to really understand how it might fail. And then once we identify what can go wrong, thinking about how we might overcome and come up with some interventions to improve on what could go wrong. So Hen, would love to hear from you and how you've kind of utilized this in your process, and
Hi,
what
Amanda.
you glean from it. Yes. Hi.
Good morning. So I know I talked about this at our individual program meeting, but I'm happy to share it here. So step one on our short form failure mode effects analysis, we were having this issue where residents were not setting a reason or like a timing for the next appointment. And so we had communicated to the whole group, you guys, when you're sending the patient up to the front desk, you have to be selecting the follow-up timing and the reason for timing in the chart before you send them to the front desk so the front desk can see it. Well, it's been that we kept seeing issue after issue where like patients were not being set up to follow up with the proper provider or with the proper timing. No reason was being set. And if they were seeing a different provider, they had no idea why they were there. So it was like a couple weeks ago, maybe, me and another team member, Dr. Wagley, we were in clinic in the morning and I had received like an appointment from a patient that was a different provider's patient. And again, like they had no idea why they were there. And I went up to the front desk and I said, hey, did you not notice that it was set, like the provider set this particular reason for follow-up? And the front desk said, well, I don't receive that up here at the front. We figured out that there was a technical issue where if you were still in the chart when sending the patient up to the front desk, it didn't update the system on the front desk side. So they were never seeing the follow-up timing, the follow-up reason, and with which provider they should be following up with. So they were just, and the patient didn't know. So once we figured out that you have to exit the chart before sending the patient up to the front to refresh the system, we fixed that right away. And now we are having no issues with setting a follow-up timing, follow-up reason, and with the specific provider.
That's great. I think that's a perfect example of why these are so helpful, where you actually lay out your process in the middle, and then you can identify, and here you identified a failure in your first step. So if you wouldn't have identified this by, breaking down your process and looking at it in each step, you may have not been successful in the project. So I love this example and how you've been able to use this. And you can see all the other areas that are highlighted in yellow are really the areas that they have identified what could go wrong or what has gone wrong, and then been able to put interventions in place to overcome those failures. So thank you for sharing. Anything else, Hen, on what's been helpful for this as a big picture? Been helpful to use this tool?
I mean, in general, it's helpful to just have this this short form failure modes effects analysis chart like handy when we are looking at data every month and trying to figure out like, oh shoot, this person like didn't get scheduled for follow-up. Well, why didn't they get scheduled for follow-up, and what do we do about it? Like, it is helpful to have it on hand so that we can identify like when we are starting to see more frequent issues with scheduling or issues with not addressing certain things at follow-ups.
Yes. And I think it also gives you an opportunity to think about, as you're continuing to improve your process, other things that you could be working on, as you continue to make the process better, more interventions that you could be working on, or more PDSA cycles that you could be working on as you continue on your QI journey. Any questions about this for Hen?
No.
Okay. Anyone else have any questions about how the team's been able to utilize this? All right. Well, thank you for sharing. And then if anyone is interested in using one of these, I would be happy to, sit down and work through it with you on maybe a next call. So just let me know. All right. Erie County. Nicole, are you on?
I am. I had to call in too because my microphone was having issues this morning. So.
That's okay. Well, thanks for calling in. Just to kind of level set and get everyone thinking in the way of a Pareto chart. This is another QI tool that you can use in your projects. And what this tool does is really, it's a bar chart and it's combined with a line graph to show the frequency of, it's really a problem solving tool to identify areas that you could work on in your process that may be failing. It's really thinking about the 80-20 rule, where we think about the vital few, or focusing on that biggest opportunity or what we could tackle to help our project move forward. So I'd love to hear from you, Nicole, on how you've utilized this and what you have been able to do in your project by utilizing this Pareto chart.
Yeah, so with this Pareto chart, we identified that there are obvious barriers to our food kit distribution. So a little bit of backstory with that to kind of remind everybody what we do. Anyone that has diabetes that comes to our health center, they are eligible to receive a food kit. We've partnered with OGO, which is a mobile food pantry, to put together food kits for patients. And when we started this project, we thought that by providing them with a food kit would maybe help give them some healthy options. We put in information in those food kits regarding healthy eating habits, just as an educational tool to highlight the importance of healthy eating in regards to helping lower that A1C. So each month when we submit our data, one of the questions that we answer is, was a patient given a food kit when they came for their follow-up appointment? And we noticed that a lot of food kits were not being given. So that's very obvious. Of 19 out of the 20 that were submitted weren't given a food kit. So we decided to dive a little bit deeper and figure out why that reason is. So as a lot of nurses know, if you didn't document that you gave something, you didn't do it. Even if you said that you did do it, it counts against you if there's no documentation to prove that. So what we decided is we huddled up as a team and we're working with our nursing staff that if you have the option to put patient refused or a reason as to why the food kit was not given. Did the patient just not want one? Did you forget to give it that day for whatever reason? So it's holding, our staff a little bit more accountable that now you need to provide a reason as to why a food kit was not given. So I'm excited to continue this because I think month by month we're going to see, I'm hoping to see at least an increase in the numbers of food kits given at each appointment. Another measure that we implemented is when we schedule follow-up appointments, in the detail of the appointment, we're putting in there give food kit as a reminder to our to our clinical staff and our providers that, hey, this patient has a diagnosis of diabetes, they're eligible for that food kit. So it kind of triggers them to make sure that they're having that conversation with the patient when they come in for that appointment that day. So I'm hoping that this is the worst 19 out of 20 not getting a food kit and that we see an increase in compliance with our staff distributing that.
Perfect. I think you have one more slide. Is there something you want to talk through on this?
I think I kind of hit it. Yeah.
Okay. Well, thank you for sharing. I think you highlighted something that I found pretty neat. As you're thinking about using your Pareto, you're actually doing a PDSA on your Pareto chart because you identified there was an opportunity to really break down the failures even more. And so thinking about continuing to use this Pareto, you probably will have a lot more categories and be able to identify maybe where your failures are happening, at a level that you can really impact. So love that you're continuing to make improvements on even using the QI tools. Any questions for Nicole and how she's been able to utilize the Pareto chart as you think about maybe using it in your QI project? All right, hearing none, I think we will move on. David Fisher-Titus, he's going to talk to us about utilizing a process map. So for those who have not used a process map or who are not familiar with a process map, it is really helpful to think about breaking down our process step by step. Allows us to see really the big picture of a process. These are really helpful as you're thinking about either starting a new process or maybe digging into a process on how you can make that process better. Really helps us to identify any unwanted variation, waste, delays, any rework that might be happening. Helps us also to engage the team as we're thinking about building a new process or making our processes better. Getting everybody into the room and talking about each step in the process really is helpful. And this is where we talk about bringing in the entire team to work on a QI project. This is really a way to help engage them and get everybody on the same page. So thinking about each step in the process. So David, I'd love to hear from you on how this has been helpful and how your team has used this in your QI journey.
Yeah, thank you, Amanda. So this process map, I really took it took it to my staff, and we kind of looked at it and tried to identify our biggest areas for improvement, especially with making sure that the patients who've been identified as new patients with high blood pressure, making sure they get that 1 month follow-up to ensure that they get any adjustments needed. What we were finding is that we are having good success with our APPs on making that happen because they're mainly getting new patients, but our seasoned physicians, for them, they're not getting new patients, but they're having patients that are aging up, and with that are starting to have high blood pressure and those types of things come to them. So those providers were just scheduling their normal follow-ups. They were comfortable with adding the medications and having the patient come back in, say, their 3 or 6 month time frame. So for them, this process map was really important because those providers, we needed to try to implement a way that we could ensure that these folks are getting addressed and seen within that 1 month. With this process, it helped us in that the thing it identified is that our patients that live greater than 20 miles away are not willing to come in 1 month just for a blood pressure check. So those that are willing do come in, and we just set them up with a nurse visit, do that blood pressure check, and have the provider either see them that day if it's necessary, if they still have high blood pressure, or just do an adjustment to their medications. So this process map helped us with that, and to ensure that our patients are getting those follow-up appointments. We have magnetic little whiteboard 3x6. They're almost like just a mini whiteboard where we write on there, BP check 1 month, and we're making sure that these folks, when they go to the front desk, they're identified that they need that follow-up within 1 month, and we're doing what we can to ensure that these folks are getting that appointment. One of the areas that we are trying to implement is some type of home BP cuff, where we can, get either have those in stock and ordered and give those to the patients, or I know some healthcare plans are actually giving patients a yearly stipend to order, Band-Aids, simple medical supplies or medications. That's a possibility for some of these patients to actually get a blood pressure cuff. I know my father has United Healthcare through the Ford Motor Company as a retiree, and he's able to order and purchase a blood pressure cuff with that stipend that they give those folks. So that's one area, if we can't find a grant, that we're going to try to
Hey,
pursue.
David,
Yes,
I
sir.
think I think Medicaid actually covers the cuffs.
Do they?
Yeah, there's a process and a form and everything else.
I did not know that. That's
Yeah,
good to know. We have a pretty high Medicaid population. Um, Thank you, sir. I
yeah,
will
that's
check
fine
into
though.
that and see what we can find. So that's how the process map, and the process map has helped our support staff, our clinical staff, and our front desk staff to ensure that these patients are getting scheduled. And my clinical staff, God bless them, my older physicians, they will, um, their words, keep them in line and making sure they're seeing these patients in 1 month. So it's great to have that type of buy-in, that they're really taking this and looking at it as another positive process instead of looking at this process map as negative. They've kind of taken it and have a staked ownership on making this work. So it's great to see that it's going through our patients, and when they teach the new staff, they're actually using this process map and showing it to them and say, this is how it's supposed to work. Now you have to make sure it gets done. And so this was a very nice teaching tool. I'm actually working on something for another task, not associated with this, but using the process map because the folks seem to really like the process map. It's very simple and doesn't have a whole lot of questions to it, so they use it pretty well. But this is kind of what we're doing at this point and seeing how we can affect our patients.
That's awesome, David. There is another slide so you can see it kind of continues on. So this is I would say this says high level, but I would say this is a little more detailed of a process map. But
Right.
I love that you were able to identify opportunities within your process by using this, where you were noticing
Right.
patients weren't coming in or weren't able to come in for those in-person visits. So you really started thinking innovatively in how to, see all these patients and started offering telehealth and the paramedicine visits so that
Right.
patients are for sure getting that follow-up in maybe different ways. And then offering them the blood pressure cuffs to go along with that. Also love that you were able to use this to help, reduce that variation in your process so all the staff know exactly what they're supposed to do. And that helps take some of the stress off their day as well. As we're thinking about burnout, these can be really helpful to make sure everybody understands what their next steps are. So thank you for sharing, David.
And Amanda, just a side note on the paramedicine, we are now experiencing quite a few more paramedicine visits, especially for those patients who are not very ambulatory, and we are offering those to these patients, and about 70% are willing to allow this to happen. So having that paramedic go out there and do the telehealth with the doctor and the patient, being able to have eyes on the patient, do their vitals. Some of the patients really like it. They're asking for it every time. Unfortunately, we can't do it every time, but
Right.
they do like that format, especially our 80 plus group. And in wintertime, we've seen an increase in this. I think we've already done in November, we did, I think, 15 here, which is quite a bit. And this month, we've already done 2 in the last 4 days. So
That's
patients
awesome.
really like it in this type of weather.
Yes, what a great resource for your patients.
Yeah, hopefully we can keep it.
Yes, for sure. All right. Well, thank you, David. I think we have Arpita is also going to talk to us about how she's used her process map at Metro Health and how that's been helpful for her.
Thank you, Amanda. So our project is about getting patients with a high ACVD risk over 10% to decrease the amount of patients from like 76% to 66%. I mean, to improve by 10%. So the process map at Metro helped with having the process go smoothly with the front desk and the MTAs and the nursing manager. That gives them like clear idea on what they need to do. So our process includes getting the list of patients who has a CVD risk score over 10% from the provider Epic dashboard. And then once we generate the list, we assign the nurse. I hand it to the nurse manager, and then she assigns a clinical team to call the patients and complete the process. So initially what they do is they go through the patient's chart to see if the patient had cholesterol labs done in last 6 months. If not, then they pen the orders for the patient, and then they call the patient and offer an appointment. And if the patient doesn't have the labs, they ask the patient to get the labs before the scheduled appointment. And then they have a process where if the patient doesn't answer, this route to the provider saying this patient did not answer or refused to schedule an appointment. And then we have a list of those patients, and we reach them again in 2 to 3 months, and we review the list every month to see if the patients are followed up correctly. And the patients who scheduled appointments, we see if they are started on statin or they declined. And if they declined, or if they want to follow up again in 3 months, we have a list to follow up on those patients to send them reminders and schedule appointments, and we call and see if they did their labs before they come in for the appointment. And patients who we are unable to reach or who are unable to schedule the appointments, we have my chat messages, and we do send letters to them, and we send a detailed message saying like why they need this appointment and what's the importance of heart risk. And there's a smart phrase that the MTAs use, so that's easy for them to like incorporate in their note. And finally, it came to a point, we achieved a lot of patient scheduling appointments, but it came to the last list where the patient either declines the statins, or it's hard to reach those patients for follow-up appointments. Some were seen in 2021, 2022, and their phones not working, or they changed PCPs out of the system. So the final list is the last one that's getting tougher, and we changed our telehealth system, which was a dedicated telehealth to in-person. So getting appointments and having patients come to the clinic for discussing just this part of the problem, like the statins, it's getting tougher. If it's a telehealth, it was more easier, but those are the setbacks that we are going through. But overall, the process is working well, and our staff is following exactly the process that we have here. Thank you, Amanda.
Thank you so much for sharing. I love that this has helped the project run smoothly, and that the staff know exactly the next steps to take on getting the patients scheduled. So thank you so much for sharing, Arpita.
Thank you.
All right. Andy, are you going to close us out?
Yes, just as a heads up, I know we're going into the holidays, but in preparation for our January clinic, be prepared to discuss how you handled your QI work over the holidays. What kinds of barriers did you encounter? Were there any surprises? Thank you to those who came to our webinar yesterday. We do already have our next one ready to go, and that'll be in February. We do invite you to register, and there is a free credit of CME if you attend. And then just the same reminders, there was a post-clinic survey emailed to you. Please complete that by next Friday, the 12th. And then your November data is due tomorrow, so please reach out to Claire if you have any questions with that. And then finally, our next clinic will be January 8th. It will be the second week since January 1st is a holiday, and that'll be on run and control charts. If you have any questions, please feel free to reach out to me or anyone else on the team. And I hope you have a wonderful holiday season.
Happy holidays, everyone. Bye-bye.
Happy holidays.